All right. So my name is Geoffrey Iwata, and I am coming from the basement because I work in this building. But I'm going to talk to you about some work we do up at the hospital that's up the hill here, where we measure biomagnetic signals with OPMs from activity that comes from TMS-invoked stimulus. So TMS is transcranial magnetic stimulation, and I'll explain that as well. We do this work in collaboration with the hospital and also with PTB in Berlin. So, here we go. So, of course, a lot have been talked about OPMs and doing biomagnetic measurements, especially on the brain and the heart. We're kind of taking a slightly different path, measuring it in the periphery limbs. This was done recently in this work over here, where they used OPMs to measure the magnetic field inside of the hand. And this is called magnetomyography, where it's the muscle activity and the nerve activity that causes the magnetic signal that is of interest. And OPMs are a really good way to do this compared to the traditional methods, which may include squids, which are bad because they're cryogenic and all that stuff. But the other traditional method is to actually take the nerve out of the body a little bit and put something around it, and that's pretty invasive. And we're trying to avoid invasive things. So we think this has good clinical relevance because studying what's happening in the brain is really important, but a lot of motor neuron diseases also affect the nerve transmission in the arm, in the hand, and studying how the signals travel through the arm is really helpful for clinicians. And if we can do that in a non-invasive way, and a way that's practical, that would be really nice. What is sort of, as I mentioned, this is sort of one possibility to do that. The other possibility that is commonly used is called needle EMG, which is also another invasive technique, where you take electrodes that are based on needles like this and put them inside the muscles to try and measure them. Of course, there are also surface electrodes, but surface electrodes measure potential differences that are on the surface, and although it can tell you information, especially temporal information about what's happening, it can be a little bit unclear exactly what the source of those signals might be. So yeah, we're really working to build as practical a device as possible so that we can actually use in a hospital environment. So the ingredients that we kind of determined that were necessary were to have a portable system, so something that's, you can move around, that doesn't require cryogens and things like that. Isolation from the environment, we want to do this inside of a clinical environment. And then because we want to have high signal to noise, we're thinking we really want something that's a triggerable response, so voluntary movement is not really ideal for that. So regarding the first 2 points, we use the twin leaf shields that, that Tom Kornack introduced earlier, and this is an alternative to a magnetically shielded room. Magnetically shielded rooms are definitely not portable, and they're also not ideal for kind of monitoring the subject or the patient that's being examined. So this is nice because we can think about periphery limbs as kind of naturally fitting inside this cylindrical shape. So, but we have to open the end caps to do that. But even with the end caps open, we've done quite a few different projects here with that and shown that it still provides the kind of necessary environment to operate an OPM. And then we can, of course, play all sorts of tricks to try and get better performance, and there are exciting things coming with pulsed gradiometers and stuff like that. But yeah, so we're trying to measure things that are kind of at the picotesla level, which is skeletal muscles, and nerves are a little bit, really at the picotesla level. The other thing about the arm is that the nerves, especially in the elbow and these kind of regions, they become really close to the surface of the skin, so it's really a nice thing to do. So TMS, I think it was discussed a little bit in the QSM workshop as well, but TMS, transcranial magnetic stimulation, is where a large and focused magnetic field is applied to the brain of a subject, and it can be up to 1.5 Tesla, it can be a little bit more. It's really a widely used technique because it's considered safe, and it's repeatable, it's quite easy to set up, and it's used to treat a variety of diseases from Parkinson's, ALS, and even depression and these kind of things, depending on where you apply it. But we're focused on using it in the motor cortex, which is directly at the top of the brain. So here's a nice subject who's sitting inside of a clinical environment, and unlike in a magnetically shielded room, there can be other people in the room having discussions. He can wear his normal clothing, and he can sit in a regular chair like this. And this is kind of what we wanted, where doctors can be in the room at the same time, and we can have sort of this kind of setup. Of course, we still have many challenges because the TMS is 1.5 Tesla. The muscle activity is somewhere in the picotesla regime. There should be a minus that's missing. Or no, sorry, that's correct. And this is open, and this coil is right here. So we're going to have really huge gradients inside. And so to kind of understand what those artifacts might be from the TMS is we have to have good control experiments. But the good thing about TMS is it's really highly focused. And because it's focused, it means if the subject moves their head down and away a little bit, like here, really we can stop all activity in the hand. So really we just set the position really carefully. And when that happens, we see the motion happen in the hand. And when they move, we don't see activity. So the motion we're trying to cause is in the hand. It's this muscle that's above the thumb, and it causes a side-to-side motion of the first index finger. And we choose this because it's a relatively isolated muscle, and the motion is really repeatable. It's also a well-known position of where to apply that. So this is a sort of schematic of our experiment. We have the shield with one end open. The hand, so we're going to be really sensitive to vibrations here because we have lots of field gradients, and we're also trying to move whatever we're measuring. So it was really important to us to develop a mount, which is not shown here, but it's attached to this suspended aluminum mount that sits outside and on a different surface, so that any motion in the hand isn't really transmitted to the sensors in the shield. And then we also want to really carefully monitor the hospital environment using other magnetometers as well that are outside of the shield. In addition to the OPMs that we have in the experiment, so we have an array in a few different configurations. The OPMs are shown in blue here. We also have surface electrodes. We tried doing gradiometry as well using stacked magnetometers. But we also use a TMS-compatible EEG helmet. And so that means we have 3 different modalities of measuring what's happening in the body at the same time. And that was really key for us. So in the first experiment where the subject has moved their head away from where the TMS would cause activity in the hand, so this is no activity, we see a large magnetic artifact, which is cut down a little bit. But this really only lasts about 20 milliseconds before it goes away. And so here the OPM channels really record nothing, and the EMG channels, which are not shown here, don't show nothing as well. This is 120 trials for this subject, and a little bit of smoothing. And we can also monitor that there's no finger movement from using a camera, but the main way we are able to determine that is from the lack of an EMG signal. Okay. So when we actually have the subject in position, we now start to see some interesting features, at least we think. So the red, thicker red trace here is the EMG. These are the electrodes that are on the actual muscle of interest. And we see what is normally seen and called a motor evoked potential. Yeah, and so this sort of happens in the same time as the TMS pulse, which is this huge thing, is starting to decay. But you can already start to see there's some features in the magnetometer channels that correspond with whatever's happening here. And then, of course, there's this huge feature that happens right afterwards, which is not seen at all in the EMG. So we can zoom in a little bit there. Again, this is 120 trials that are averaged together. And so looking a little bit more carefully at the motor evoked potential, the time that happens here, we see a similar latency in the timing of the EMG and with the MMG signals. So that's good. And then we see kind of this big thing here. And so we did this for 4 subjects and really carefully controlled for vibrations, and we still see this big feature. So we're really interested to see what this is, of course. And we can kind of see that there are different time points that are of interest. But fortunately, we also have the EEG measurements to help us examine what's happening here. And so even at the point where the motor evoked potential happens, Mostly what we see in the brain is just residual artifacts from the TMS still. So this is exactly the point in the motor cortex where we applied the TMS pulse, and so we see a lot of activity there. But across all 4 subjects, what we rapidly see as we go into this region where there's additional activity, which for some subjects looks like this signal, this kind of up and down signal. For others, it might be all positive. We see the activity spread to different regions of the somatosensory part of the brain. So yeah, we're working with clinicians right now to try and understand exactly how to analyze this, how to explain this most effectively and most convincingly. But critically, we see this really happening consistently across subjects, and that's really cool for us. Okay, and then what we also find is that even though we take 120 trials, so the TMS, it's repetitive, and we run it at 0.5 hertz, which is more or less comfortable for the subject, and we take 120 trials, but in fact, we can get away with only doing 50 trials before the latency of the signal, which is kind of a measure of how well we can characterize where things are happening, becomes kind of within a standard deviation of the final value. So we're kind of overtaking data a little bit. Yeah. So what's next? We kind of still want to do some needle EMG measurements. We've tried this in the hand, but the muscle that's here is so shallow that it actually doesn't make so much of a difference whether you're measuring on the surface or below. But we're thinking that maybe in other parts of the arm, we might be able to use needle EMG to really understand where our additional signals are coming from. We're working on source location. Of course, our position of our sensors is not ideal for doing source location. It's not really like a neat little array. It's sort of wherever in the shield that the sensors can fit. But we can still try and do some forward modeling of what's happening based on what we know about TMS and see if the signals match what's happening there. And finally, we want to really try and get a longer array of sensors, so maybe a longer shield, so that we can really start to measure signals from all the way up the arm that are coming down, and then we can do timing measurements of how quickly these signals are progressing down the arm, because this really tells us something about the health of the nerves that we're measuring. So yeah, I mentioned that here, and yeah, so as I mentioned, we've been working with the doctors at the university hospital here, and that's been a really helpful collaboration, especially since we're hoping to start to try and expand this and measure not just in healthy subjects, but maybe patients as well. Okay, so yeah, with that, I'd just like to thank my colleagues here at JGU and the HIM, my colleagues at the hospital. They have a poster here today, and Tilman Zander, who's right in front of us, right here. And yeah, so thank you.